Okay, I think we should start. So you all take a seat. My name is Lorenzo Gallon. I'm the co-chair with Fritz Herbert Deichmann. It's a pleasure for me to introduce today Professor Albert Sanchez-Fuello. Professor Sanchez-Fuello is a pathologist at the Institute of Liver Disease at the King College of London. He receives MD in the University of Barcelona and PhD in transplant immunology. Most of his work is related to immunobiology and tolerance, specifically in liver transplant. And today he will discuss with us how he's able to achieve, and has studied patients with liver transplant, able to achieve basically tolerance through cellular therapy or different mechanisms. So thank you so much and welcome.
Thank you very much. Thank you very much for the invitation. It's a pleasure to be here. So I've been told to give the presentation in English, but feel free afterwards, please, to ask questions in Spanish if you prefer. Two important kind of disclosures. The first one is that I'm not a nephrologist. So about the clinical applicability of some of the things we'll be discussing, I welcome your thoughts. Okay, I won't provide you kind of a guidance in that regard. And the second one is that I have a very kind of a relevant commercial kind of conflict of interest, which is I'm the founders of this kind of a biotech company where we have a specific interest in generating engineered regulatory T cells to induce immunological tolerance in transplantation and autoimmunity. Okay, so let's start with some terminological kind of clarifications, what we understand by immunological tolerance, which from a more fundamental immunological standpoint, we define as the lack of donor-specific cytopathic immune responses in the absence of immunosuppression and in the presence of normal immune responses against other antigens not expressed by the alloantigen. So antigen specificity is a key component of the transplantation tolerance concept. And in animal models, where it's quite kind of easy to induce tolerance, particularly in vascularized allografts, when tolerance depends on immunoregulations, there are a number of very specific phenomena that can be demonstrated. The first one is that the tolerance phenomenon is self-perpetuating after the initial tolerogenic induction protocol. The second thing is that it can be transferred to other lymphocytes that were not originally tolerized at the time that the treatment was administered. This is the concept of infections tolerance. And the third one is that there is a phenomenon that we call of link suppression, which means that the tolerance can be actually extended to antigens that were not initially kind of present at the time that tolerance was induced, provided they are expressed by the same antigen presenting cell. Now, in the clinic, we can kind of rarely kind of clearly demonstrate all of these different kind of immunological idiosyncrasies, and we use this pragmatical concept of operational tolerance. Basically, we define someone as operational tolerant if the allograft is alive, without immunosuppression, and without us being able to demonstrate that there are ongoing destructive immunological responses. Now, is tolerance kind of a desirable outcome in clinical kidney transplantation? So I would say that yes, kidney transplantation is the best alternative to kind of long-lasting dialysis, but as you know much better than me, it's not a kind of a definitive treatment. There is a large proportion of patients who lose their allografts 10 years after transplantation. So if we are able to much better control donor-specific responses by inducing tolerance, we might be able to achieve this kind of a dream of one kidney transplant for life. We presumably will kind of improve patient outcomes, reduce costs, improve quality of life, et cetera, et cetera. Now, how can we achieve tolerance in the clinic? So basically, we exploit our kind of the same mechanisms that our body utilizes to induce tolerance against self-antigen. So there are two kind of fundamental mechanisms. We call kind of a central tolerance the kind of deletion of our T cells capable of recognizing our autoantigens, and this is a very effective way of pruning a large component of the autoreactive T cell repertoire, but this is not kind of complete. We all have kind of autoreactive T cells in the circulation, and these are kind of kept at bay by the kind of effect of a number of peripheral tolerance mechanisms. The most probably kind of potent and well-known is the effect of regulatory lymphocytes. Now, this is kind of a very much T cell-centric view of immunology, but similar things happen in what regards B cell tolerance. Now, from a therapeutic standpoint, we can just try try to kind of replicate what nature does spontaneously to try to intentionally induce transplantation tolerance. And we use the two mechanisms I just alluded to. We can actually exploit the capacity of the thymus to eliminate T cells with specific specificities by repopulating the thymus with donor cells so that those T cells that are donor-specific are actually killed within the thymus. And then we can also kind of exploit these peripheral mechanisms by, for instance, augmenting the function or the number of these regulatory lymphocytes to try to tip the balance between the T cells that provoke rejection and those that are capable of suppressing cytopathic responses. So these two kind of fundamental mechanisms is what we have exploited in animal models, but also in the clinic to try to therapeutically induce transplant tolerance. And in the clinic, in kidney transplantation, most of the strategies have involved the use of one type or another of cell therapy. And cell therapy in this context is used for different purposes. We use hematopoietic stem cells in order to try to repopulate the thymus with donor cells and achieve this kind of concept of central tolerance. And then we also use a variety of different regulatory cells to try to suppress cytopathic effector immune responses in the recipients. And there are also trials that have used a combination of several of these different cell types. Now, this table summarizes the key kind of experience in trying to induce tolerance in kidney transplantation that have happened over the past kind of 3-4 decades. And I will briefly touch on the kind of what I think are the most kind of successful ones. There are 3 different kind of experiences in using this or exploiting this concept of central tolerance, basically by using hematopoietic stem cell transplantation simultaneously with kidney transplantation. One is the experience of the Mass General Hospital in Boston. The second one is the experience of the kind of Stanford group originally led by Sam Strober. The third one is the experience kind of led mostly by Susan Ilstad and the Northwestern group. And then there is a kind of a number of groups that have attempted to use peripheral tolerance mechanisms using kind of immunoregulatory cell therapy to induce kind of a tolerogenic environment. This is kind of there is kind of experiences in using just regulatory lymphocytes that have been expanded in the laboratory, but also more recently using kind of cells that are not only expanded in the laboratory, but also genetically modified so that we artificially kind of confer donor-specific reactivity. And finally, there are kind of a number of strategies that have tried to exploit kind of combinations of what I have just kind of described. As you will see, kind of as you see in the kind of in the table, the only strategies that have attempted to really demonstrate this kind of concept of completely immunosuppression-free tolerance are the strategies exploiting these central tolerant mechanisms, which consist in kind of administering hematopoietic stem cell transplantation at the time of kidney transplantation. The strategies that are trying to boost immunoregulatory mechanisms as the fundamental way to achieve tolerance, in fact, from the clinical standpoint, they have only kind of attempted as a primary endpoint of kind of extreme kind of minimization rather than the complete discontinuation of immunosuppression in kidney transplantation. In other organs, for instance, in liver, we have attempted to kind of completely stop immunosuppression using these type of strategies, but not yet in kidney transplantation. So let me just go into more detail in some of these experiences that I think are the most kind of relevant for kind of clinical kidney transplantation. Now, this is the experience from the kind of Stanford group, originally led by Sam Strober, in using hematopoietic stem cell transplantation with kind of a conditioning consisting in total lymphoid irradiation and ATG to induce kind of a situation of mixed hematopoietic chimerisms, in this case, the kind of hematopoietic stem cells come from the donor, and to be able to completely stop immunosuppression. This has been very, very successful, with the caveat that it has only worked in HLA identical donor-recipient pairs. But there is kind of a substantial kind of experience, and the paper that was published a few months ago, this in 2025, is the first kind of ever phase 3 randomized controlled trial, multi-center, of tolerance induction in kidney transplantation, and the results were actually quite striking in that 75% of the patients who received this treatment were kind of completely with immunosuppression. They have been off immunosuppression for more than 2 years, and the group from Stanford, they have a larger cohort across the kind of past 2 decades of similar kind of successes, also kind of in HLA match donor-recipient pairs, and they have actually, as you see in this survival curve here, they have actually compared the kind of long-term survivals of these allografts with contemporaneous HLA identical transplants in their institution and demonstrate that those that actually achieve tolerance, they have a better kind of long-term allograft survival. So this is by far the kind of the best established strategy to induce tolerance in this kind of a very selected kind of a group of patients. This has proven to be very safe. There haven't been episodes of graft versus host disease, and there haven't been kind of a major infections complications. Now, there is an alternative approach. The problem, however, is that, as I was mentioned before, the same strategy when used in HLA mismatched recipients, it hasn't actually led to the establishment of mixed chimerism, and it hasn't led to the kind of a feasibility of stopping immunosuppression. Now, this is the experience from kind of Northwestern that applied kind of a similar strategy with a much more aggressive conditioning. Here, patients receive cyclophosphamide, fludarabine, total body irradiation, and conventional immunosuppression with the use of a kind of very special kind of type of immune cells, what is called a facilitating cell, together with hematopoietic stem cells to try to achieve not a mixed chimerism, but a complete replacement of the kind of a hematopoietic system of the recipient by that of the donor without inducing graft versus host. And this has been quite successful as well in what regards the proportion of patients treated with this strategy that achieve a discontinuation of immunosuppression across HLA barriers. However, there are kind of concerns about the safety of this strategy. There was kind of a phase 3 trial, a multi-center randomized controlled trial using this strategy that was prematurely terminated because one patient died out of kind of a severe acute graft versus host disease, and there are other patients that have developed graft versus host disease as well. And the kind of industrial or commercial development of this strategy has also been kind of complicated. This kind of the intellectual property of this kind of facilitating cells was originally licensed to Novartis. Novartis actually never developed it, gave it up. It was taken up with from a biotech, Talaris, which actually suspended their operations about kind of 1 or 2 years ago. This is now kind of in the hands of another biotech, Immunofree, which are trying to kind of modify this strategy to intervene to administer the hematopoietic stem cell transplant later after transplantation, about 2-3 months, and doing kind of a better matching between donor and recipient to try to reduce the risk of graft versus host. So this is very much kind of still an ongoing kind of a strategy, although it will need to be tweaked if we want to really improve the safety profile. And then there is a third kind of a strategy also of trying to achieve a mixed hematopoietic chimerism led by Benedict Cosimi and David Sachs in the Mass General Hospital in Harvard, but with a much kind of a smaller kind of experience, only 10 patients treated, worse kind of outcomes in terms of tolerance, and also kind of issues about kind of safety concerns. Not so much graft versus host, but something that was kind of described as kind of engraftment kind of syndrome, and in fact 3 of these 10 grafts were actually lost. And these are, of course, in all of these trials, the creme de la creme of our kidney transplant recipients. These are kind of a living donor, kind of usually kind of very well selected. So the outcomes were not very, very kind of successful in this strategy. Now, if we move to the kind of the additional bucket of tolerance-inducing strategies, those that actually exploit peripheral tolerant mechanisms, the kind of a strategy that has been employed the most is the use of the so-called regulatory T cells. And these are the CD4 cells that express CD25 and the transition factor FOXP3. These are the cells for which Shimon Sakaguchi won the Nobel Prize last week. So they are very, very kind of timely. And these cells are quite kind of unique in that they have a variety of immunosuppressive mechanisms. They can basically suppress every single kind of arm of the immune system. They can also be grown in large numbers in the laboratories. They are T cells, which means that they have a define T cell antigen specificity, which we can try to kind of redirect towards our needs. And there is significant amount of experimental data in preclinical models demonstrated that if we give lots of these cells, we can actually induce tolerance across a variety of different preclinical systems. The caveat here, which is important when we think about the clinical translation, is that in animal models, in order for this to work, one needs to give lots of cells and or combine this with some sort of lymphodepletion to deplete the number of alloreactive T cells that are there at the time that the cells are infused. Now, there is kind of one proof of clinical efficacy. This comes from the kind of bone marrow transplantation in using these Tregs as a means to prevent acute and chronic graft versus host disease. And this is kind of experience from the group in Stanford. And this was actually very, very successful, but it's important to keep in mind that because these are heavily lymphodepleted patients, these are kind of patients with hematopoietic malignancies receiving bone marrow transplantation, the kind of a number of Tregs that it administered, which is not huge, 3 million Tregs per kilo, represents a huge number of Tregs as compared with the existing lymphocytes that the recipient has. And to achieve, as you can see here, a 1-to-1 ratio of effector T cells to regulatory T cells is not something that we can readily achieve in normal, non-heavily immunodepleted transplant recipients. So this works in the clinic, but there are caveats as to how we achieve this very high ratio of regulatory to effector T cells. Now, we can, however, try to make these Tregs better. So the experience here in Stanford was just taking these cells out of the body, growing them in the laboratory in non-specific conditions, but we can try to improve their potency, and we can do that, for instance, what we call second-generation Treg products, by culturing them with donor cells, so that those cells that have donor specificity are those that preferentially grown. And more recently, and this is probably where the field is going to be moving on, we can genetically engineer these cells so that they only recognize some of the alloantigens expressed by the transplanted organ. There are ways of also growing these cells in vivo in the patients themselves, and we have exploited this, or we have studied this in liver transplantation by using low-dose IL-2, but that's not something that I will have time to discuss today. So in kidney transplantation, probably the best-known kind of initiative of using regulatory T cells is the so-called the ONE study. This was a European consortium study where a number of different groups agreed on a kind of a predefined clinical protocol and then compared the effects of different cell products. Although 4 out of the 7 cell products that were studied were actual regulatory T cells. Now, the endpoint of the kind of experimental group was to achieve monotherapy with tacrolimus, and you need to tell me whether you think this is a relevant kind of endpoint to achieve by using cell therapy. The truth is that 40% of the patients achieved this endpoint. The control reference group was kept on conventional immunosuppression. There was no attempt to minimize immunosuppression in the reference group, but there appeared to be fewer kind of episodes of infection in the patients who received the cell therapy. So there was kind of a hint, although not very, very robust, of potential clinical efficacy. And what is very, very well established is that this was actually very, very safe. In kind of a Northwestern, there was kind of a concurrent study using also, these were polyclonal Tregs without predefined alloantigen specificity, combined with induction with alemtuzumab, and it was very clear that kind of there is a synergistic effect of lymphodepleting and giving Tregs, so the Tregs expand much better if the recipient is given kind of a heavy kind of a lymphodepletion. Now, I mentioned, so that we are still lacking kind of a very robust kind of demonstration of clinical efficacy, but the field of the technology has been moving, and clearly where kind of most of the kind of interest now lies is in trying to make these cells even more powerful by artificially modifying their antigen specificity. And this can kind of be achieved, for instance, by using the chimeric antigen receptor technology in the same way that is being used to kind of treat kind of CD19 malignancies, and the antigen, not surprisingly, that has been kind of chosen for the first clinical application is HLA-A2, because 25% of our transplant population are mismatched for HLA-A2. So here the strategy is to select patients who are HLA-A2 negative and have received an HLA-A2 positive kidney, generate this autologous T-cell product by engineering the cells with a CAR that recognizes HLA-A2 and injecting the cells with the hope that they will actually preferentially migrate to the allograft or the secondary lymphoid tissues. And there is a kind of an ongoing clinical trial trying to do this. This is the Steadfast trial, which is kind of ongoing. 8 patients have been dosed. The endpoint here, again, is achieving monotherapy with tacrolimus. The problem is that the biotech that was actually sponsoring this study closed down their cell therapy kind of a division a year ago, and the trial is no longer enrolling more patients. So it's kind of, and this is still kind of unpublished, so it's difficult to kind of see how this will actually continue in what regards this specific trial, although there are kind of additional groups that are trying to exploit similar strategies. Now, the fact that we are dealing with a transgenic cells that we can identify completely changed the way we can monitor these cell therapies. And this is data from my own laboratory and our kind of spin-off company, Qual Therapeutics, in trying to detect these engineered cells in the circulation, in this case of liver transplantation. As you can see in the kind of dot plots in the right, we can actually detect these cells in the circulation more than 6 months after infusion. We can take these cells out of the body in this patient kind of 1 year after infusion and demonstrate that these cells remain immunosuppressive and immunoregulatory. And we can also, and these are kind of liver transplant biopsies, detect these cells in the allograft cells. And this is quite striking in that, although there is only a few squares in this kind of in these pictures, this actually represented some of these patients 50 or 60% of the total number of Tregs in the liver. So we are really capable of repopulating the liver with regulatory T cells that are specific for HLA-A2, although we still don't know whether this will allow us to completely stop immunosuppression. So I'm going to finish very, very soon. There are a number of kind of additional strategies of combining several of these different cell therapies studies. There is an ongoing trial in Vienna of combining hematopoietic stem cell transplantation and polyclonal Tregs. The idea here is to try to achieve some sort of a mixed chimerism without the need of heavy conditioning, and the endpoint was achieved kind of a monotherapy with belatacept, but unfortunately, out of the 6 patients, there were several episodes of rejection, and I think that the trial kind of failed. And there was, and this remains unpublished, there is an additional trial that was very, very kind of recently published, trying to achieve a similar objective of monotherapy with belatacept, but in this case, giving kind of repeated infusions of mesenchymal stromal cells from the donor. This again failed. Several of the patients rejected, and what was probably a bit more of concern is that by using MSC cells, the patients were sensitized and they developed, in fact, anti-HLA antibodies. So this is probably kind of a strategy that will be abandoned. And finally, kind of some of you might have seen this recently published paper of kind of using not CAR Tregs but CAR T cells, and this is kind of just one case report, but it's quite kind of striking, of a kidney transplant recipients with kind of a refractory CD19 hematopoietic malignancy treated with anti-CD19 CAR T cells. In whom immunosuppression after the CAR T cells were administered was not reinstituted, and this patient has been off immunosuppression for more than 2 years, which is quite kind of striking, and is aligned with this observation in autoimmunity in lupus of CAR T cells being able not only to kind of reprogram the B cell compartment, but also somehow having a tolerogenic effect on the T cell compartment that are apparently not touched by the CAR T cells. So clearly kind of a very interesting kind of a concept to exploit further. So I conclude with this kind of a slide. I think that it's unquestionable that tolerance can be achieved in kidney transplantation. There is a very, very kind of a well-established experience of doing so in HLA match recipients with a very good safety track record. record. There is demonstration that this can be achieved across HLA barriers as well, although the issue of the kind of a toxicity of these regimes, I think that remains a serious concern. In what regards using less aggressive kind of strategies based on peripheral immunoregulation, regulatory T cells have proven to be safe. There is a very strong rationale to actually engineer these cells to make them super potent, but we still lack the definitive proof of clinical efficacy. And there are significant challenges in pursuing this research. The reliance on cell therapy strategies is problematic. This is very cumbersome, very, very expensive. There is kind of a very, very strong kind of a dependence on the academic groups leading on the research, and the interest by the kind of a big pharmaceutical industry has been limited, although there has been kind of a strong interest from venture capitalists and biotechs. This is, of course, kind of usually a very short-term type of investment, which actually is difficult to be maintained in time. And finally, particularly in what was peripheral tolerance, I think that there is kind of we need a kind of a serious discussion of what are the kind of desirable endpoints. And then I would welcome your thoughts. Is tacrolimus monotherapy a suitable kind of endpoint when we're using such an specific strategy? So I think this conversation of how these strategies are positioned in the big scheme of what is happening in kidney transplantation across the commercial studies is a kind of a debate that is somehow still lacking. So thank you very much. I'll stop here.
Well, thank you very much for this excellent talk and very, very interesting. Are there any burning questions? If there's, you can maybe think about questions for 30 seconds, and I will ask one in the meantime. It seems that most of the studies that you presented, at least in kidney transplantation, are aimed for immunologically relatively low-risk patients, rather with the objective to minimize or reduce immunosuppression and thus minimize the effects of the immunosuppression. However, there's a group of patients that probably most of us here in the room are very, very worried about. Those patients, at least potential kidney transplant recipients with presence of a high percentage or of a high number of HLA antibodies that are difficult or impossible to transplant. How would you see this patient group with the therapies that you've just presented?
Well, you've seen how difficult it is to achieve tolerance across the kind of a creme de la creme recipients. To go for the kind of a more difficult kind of a patients represents a challenge. Of course, there are other cell therapy strategies that are not depending on telogenic mechanisms, just on killing kind of B cells that are incredibly kind of promising. In fact, with our kind of a spin-off company, we are developing a CAR-Treg against CD19 and to try to control the B cell compartment. Whether this is a kind of a non-killing alternative to the CAR T cells in kind of to try to treat sensitized patients remains to be seen. But I think that this is the point I was trying to kind of to make, that I think it's important to kind of position these strategies within the big landscape of what is the kind of the problems in kind of kidney transplantation. I think this is kind of a wishful thinking to expect that this will provide a cure across all kind of patients. I think that we will still need to stratify patients according to risk, and there are patients who I think that there is a kind of a good chance they will be able to benefit from this type of strategies, but of course not all of them.
Okay, have you thought about any questions from the
I
audience? You can ask in Spanish as well. We can.
Thank you so much for your nice talk. And very. I am wondering about this therapy and the impact of the cancer in these patients. If you are keeping it, do you think there is some kind of risk if you inducing this Tregs therapy, or you have, because there is some kind of Tregs or T cell population that are developing in the long-term cancer appearance. Do you think there is a risk with these new therapies in test to have more cancer in the future?
Hypothetically, yes. So yes, kind of Tregs accumulating cancer. They are actually very well linked with cancer progression. The track record of using these Tregs in transplantation and in patients with quite heavy immunosuppression has been very, very good. So kind of they're having any hint that this actually increases kind of skin cancer. Having said that, again, one of the kind of additional incentives for actually going for highly donor-specific cell products is to actually ensure that we minimize the chances of the cells immunosuppressing kind of responses against third-party antigens.
I have a question in regards to the new agent that might come for us to use in transplant. Most of them, as you know, they try to avoid CNI, anti-CD40 ligand, and there are 2 companies already that are doing trials. Do you think this medication will interfere in positive way or negative way with the possible tolerance studies? How do you see the combination of Bella, anti-CD40 ligand for many of our patients? So we're potentially going to move away completely from CNI, and would you think those medications will play a role?
So in what regards, for instance, the use of kind of a regulatory lymphocytes, kind of a belatacept seems to be harmful for that kind of a homeostasis, but there is quite a strong kind of a synergistic effect with anti-CD40 ligand. So in preclinical models, in fact, the combination of CAR-Tregs and anti-CD40 ligand is actually very, very powerful. So this is clearly kind of if I was to redesign some of these clinical trials, and you ask me what would be the ideal conditioning agent for Tregs, it would be an anti-CD40 ligand antibody. But there is another kind of a component to your question, which I think is important, and for me is still kind of an unsolved issue, is how come some of these commercial trials are kind of focused on kind of removing CNIs, where one of the endpoints of these more proteologenic studies is actually moving to tacrolimus monotherapy rather than removing CNI. So I think that's a very fair kind of criticism of kind of some of these studies. Yeah. I agree with you.
I know that you studied for many years tolerance in liver transplant patients. It's been reported to be quite high, 40–50% after many years post-transplant. For me, also for the audience, why do you think liver is easier and kidney is more complicated to tolerize?
So the liver appears to be doing some of the kind of same function that the thymus achieves. So it's capable of kind of pruning a significant component of the alloreactive T cell repertoire. And this happens in all of the patients. If we actually quantify kind of alloreactive T cells by doing TCR sequencing before and after liver transplantation, there is a clear drop of alloreactive T cell clones in liver, and we don't see the same thing in other organs. So the liver seems to be doing some of the work spontaneously, which kind of lowers the barrier for some of these tolerogenic kind of strategies. And in fact, there is a study I didn't mention here in liver transplantation from Japan, where the use of kind of a cell product enriched on regulatory cells was actually very successful as inducing tolerance in liver transplantation.
If we ever see cell therapy in routine clinical practice, in terms of the economic impact, is there anything you can say about that? Any idea in which range we are moving?
I mean, it's difficult to forecast if some of these strategies were highly kind of successful, how much the economy of scale would allow to reduce costs. But this is, of course, GMP production of cell therapy is very expensive. The kind of the running cost of generating one dose currently is in the order of kind of probably 60,000 kind of euros. Okay. There is a strong incentive, and we have a program in trying to generate kind of regulatory cells from iPS to try to kind of have a universal kind of a bank of cells, not an autologous product, but a kind of a universal kind of a cell product that would significantly kind of reduce cost. So I think that the cost, of course, is a kind of a potential kind of a concern, but if one of these products was actually kind of a highly successful, I think that there would be strategies to lower the cost to make this a kind of a competitive strategy.
If we looked at equivalence of dialysis years, maybe the cost is not that high, but it might be just one and a half years of the cost of treatment. So,
yeah. I have a question regarding so if the xenotransplant would be the solution for the supply-demand of kidney transplant we have for our patients. how do you foresee, since these patients, as you know, the few of them, they're alive and they've been doing relatively okay, but they receive massive amount of anti-rejection therapy at the time of transplant. How do you see this kind of work because obviously, to help us to eventually tolerize humans towards pig antigen?
Yeah, I think that on the one hand, one would actually think, well, these are kind of a very, very, very stringent immunological barriers. This is not where you would explore this type of strategies. On the other hand, precisely because of the very, very heavy burden of immunosuppression of the recipients that are receiving xenografts, I think that a little bit kind of a counterintuitive, there could potentially be a room to actually use cell therapies that have proven to be very safe if they are able to burden that kind of immunosuppressive kind of effect. And what I have described here today is kind of the very, very basic type of genetic modifications that we're using to generate, for instance, these CAR-Tregs. But these cells can actually be engineered to be much more kind of potent, to be able to survive in the presence of heavy kind of doses of calcineurin inhibitors by having kind of intrinsic kind of IL-2 signaling.
Yeah.
They can be designed to actually produce additional kind of proteologenic factors. So we view these cells in a way as somehow vehicles to administer kind of medicines at the kind of site where they're actually needed. So I think that there is room for kind of in the same way as some of the kind of xenografts that have been used have 10 or more genetic manipulations,
yes.
The same thing can actually be achieved with these cell products to make them much more powerful and much more targeted.
So there's going to be a lot of work to do. Yeah.
Maybe they're complementary. I believe the second xenograft kidney that was transplanted in New York was transplanted with thymus cells. So it was already combined with some kind of cell therapy in a certain sense. So maybe the therapies might be complementary finally.
Yeah.
Any more questions? Any more ideas, comments? I think we've very well used up our time. Thank you very much. Thank you very much for the interesting talk and the interesting discussion. And I'm sure we'll have to meet again in the next couple of years and see how the evolution has gone.
Thank you.
Thank you.